My name is Dr. Geeta Sinha. I am with the Department of Anatomy and Neurobiology with Faculty of Medicine. This is my first video of the Pelvis and Perineum series. In this video, I will be talking about the three important regions of the pelvis and perineum. First, the osteology, then the muscles of the pelvis, and lastly, the blood supply of the pelvis. On this bony pelvis, I am going to demonstrate some of the bony features which are important landmark for your clinical practice. I am also going to take a male and female pelvis, and I am going to demonstrate what are the different features which differentiate these two pelvises from each other. On this articulated pelvis, I am going to demonstrate some of the bony features. Pelvis means basin, and this basin is formed by the union of four bones. We look here, this is your right hip bone, this is your left hip bone. In the posterior aspect, we see the continuation of the vertebral column. This bone is known as sacrum, and here the inferior aspect is the coccyx. Let me describe you the position of the pelvis in erect position. The pelvis is inclined to 80 degrees, and by inclination you rotate the pelvis forward to 80 degrees till the anterior superior iliac spines, these are these two bony points, and the pubic tubercle, these are two bony points, they come onto a vertical plane. And this is, in this position, you can see the inlet of the pelvis is at an inclination, which is called as inclination of the pelvis. So the pelvis is not stays in this position, but it is rotated downwards and forwards. We're looking at a pelvis which is suspended by a rod. To see the position of the pelvis in erect position, I will try to rotate the pelvis. There is a pointer attached to the right anterior superior iliac spine. When this pelvis is rotated at 80 degrees, which is this position now, this is the normal position of the pelvis. The anterior superior iliac spine and pubic tubercle are lying in the vertical plane. The pelvic inlet is at an inclination, and that is the normal position of the pelvis. The right and the left hip bones are joined together on anterior aspect by fibrocartilaginous joint. This is known as pubic symphysis. There is a fibrocartilaginous disc which attaches the two parts of the hip bone. On the posterior aspect, the sacrum, which is joins the two right and left hip bone, and this is formed by the 5 vertebrae which are fused together. On the anterior surface of the sacrum, we find 4 different openings, and these openings are known as anterior sacral foramina. The ventral rami of the sacral nerves exit through these openings. On the posterior aspect of the sacrum, there are openings, and these are dorsal sacral foramina. Dorsal ramus of the sacral nerves exit through these openings. The anterior and superior margin of the first sacral vertebra has got a projection which is known as sacral promontory. The fourth bone, which only we can see the partial part of it, is the coccyx. The coccyx is formed by the fusion of the four coccyx vertebrae. Let's look at some of the features of the hip bone. The hip bone is formed by the union of three bones: the pubis, which is the anterior part of this bone, ischium, which is the inferior part of this bone, and ilium, which is the superior part of this bone. This cavity here is known as acetabulum cavity. This is where the three bones come and join together by a Y-shaped junction at the age of approximately 16 years. Let me show these three bones on skeleton, which is at the age of 2 years. On this bony model, I'm going to show you the junction of the three bones, and this is the Y-shaped junction where the three bones of the hip bone are meeting together. You can see that there is the ilium. This is the pubis coming from anterior aspect, and here is the ischium coming from the inferior aspect, and this is the joint where three bones are meeting together. Now I'm going to demonstrate some of the bony features of the pubis. The pubis is the anterior aspect of the hip bone. This is the body of the pubis. It has got two ramus, superior ramus and inferior ramus. If you pass this probe from the pubic symphysis, this is the pubic crest, and this projection here is known as pubic tubercle. This edge here is the pectineal line. This is the inferior ramus of the pubis, which fuses with the ramus of the ischium, and this is known as ischiopubic ramus. This opening here is known as Obturator foramen. This bone here we are looking is the ischium. This is the inferior part of the bone, and this projection here is known as ischial tuberosity. The ischial tuberosity is the area which we usually sit on. So this here is the position in a sitting position of the pelvis, and you can see how both of the ischial tuberosity are grounded onto the base or the floor. One of the important landmark of the ischium is this is known as ischial spine. Between the ischial spine and the tuberosity, we see there is a small arch, and that is known as lesser sciatic notch. Let me show you by my probe. This is lesser sciatic notch, and there is another notch which is superior to the ischial spine, is your greater sciatic notch. Some of the features which we like to see about the ilium. The ilium has got a free edge on the superior aspect. This is known as iliac crest. The pointed end onto the anterior aspect is known as anterior superior iliac spine, ASIS. It's a very important landmark for the surface anatomy. This point here we're looking is known as anterior inferior iliac spine. On the posterior aspect of the ilium, we see there is the posterior superior iliac spine and posterior inferior iliac spine. On the outer lip of the iliac crest, on the anterior aspect, we see a projection here. This is known as iliac tubercle. This fossa, which we see on each side, this is known as iliac fossa. Now I'm going to show the pelvic brim or pelvic inlet. This is the inlet which divides the pelvis into two areas. Above this or superior to this pelvic brim, we have got false pelvis, and inferior to this area here is the true pelvic cavity. The pelvic brim is formed by if we start from the pubic, anteriorly from the pubic symphysis, by the pubic crest, pectineal line, arcuate line, ala of the sacrum, and the sacral promontory. This diamond-shaped area is the outlet of the pelvis, which is formed from anteriorly by the pubic symphysis. On right and left side, ischiopubic arch or ramus rami, Sacrotuberous Ligament, and tip of the coccyx. On the posterior aspect of the pelvis, there are two ligaments which stabilize the pelvis, Sacrotuberous Ligament and Sacrospinous Ligament. Let me show you the Sacrotuberous Ligament. The Sacrotuberous Ligament is a triangular ligament. Superiorly, it is attached to the body of the sacrum and the coccyx. The inferior attachment is the ischial tuberosity. So on the right hand side and the left hand side. This ligament changes the lesser sciatic notch into an opening, and this opening is known as lesser sciatic foramen. Through the lesser sciatic foramen, many of the nerves, vessels, and muscle exit or enter in the region of the gluteal region or the perineum. Sacrospinous ligament, which is this ligament here, we cannot see the other aspect. Maybe if I rotate the pelvis, you can see there is this triangular ligament attached to the lower part of the sacrum and the coccyx. This ligament comes and attaches to the ischial spine, and that is your sacrospinous ligament. Sacrospinous ligament lies on the posterior aspect of the coccygeus muscle. The attachment of the sacrospinous ligament transforms this greater sciatic notch into the greater sciatic foramen. This is another big opening in the pelvis through which muscle, nerve, and the vessels exit from the pelvis in the gluteal region. On the anterior aspect of between the sacrum and the ilium, there are ligaments which join the sacrum to the ilium, and on same thing in the posterior aspect, we see these are posterior iliosacral ligament and anterior sacral ligament. On the anterior aspect of the pelvis, over the obturator foramen, on the left and right side. This green area represents the obturator membrane. The obturator membrane closes the obturator foramen and gives attachment to muscles. On the superior aspect of the obturator membrane, there is a small opening on each side. This is where the position of the obturator canal. Through these openings, the obturator nerve and the obturator artery leaves the pelvis and enters the medial aspect of thigh. Now I have got two pelvises. There is a male pelvis and there is a female pelvis. Let's compare some of the features between male and female pelvis. Female pelvis has a functional aspect. During the vaginal delivery, the baby has to pass through the true pelvic cavity. Let's compare the inlet of the pelvis between the two pelvises. This is heart shape. It's difficult for a baby's head to pass through here. Look at the wide, round pelvic inlet. Let's look at the pubic arches, acute pelvic angle, while there is a wide pelvic angle. The cavity here is shallow, it's quite deep and funnel shape, and if we look at the outlet, which is through which baby's head is going to crown, we can see in the female pelvis the outlet is very round. By looking at the opening into the male pelvis, it's more diamond shaped or more heart shaped, and you can see the ischial spines are inverted, which makes it difficult for baby's head to pass. Now I'm going to demonstrate the muscles of the pelvis. For this demonstration, I will be using models and bed prosection. There are two groups of the muscles in this area. The muscles of the lower limb, so there are two muscles which will be functioning on the hip joint. And then there is the muscle which forms the floor, pelvic floor or pelvic diaphragm. I will be talking about the location, the components, and function of this floor. Especially this floor goes through a lot of stress during the vaginal delivery. The stretching and the tear into this floor can cause prolapse of the uterus. It can lead to prolapse of the bladder or rectum, and it may cause fecal or urinary incontinence. On this model, I'm going to demonstrate the muscles of the pelvis. There are 4 muscles which are found inside the true pelvic cavity. 2 of the muscles are the muscles of the lower limb, and 2 of the muscles form the pelvic floor. Piriformis and Obturator Internus are the muscles for the lower limb. Let me demonstrate the position of the piriformis muscle. The piriformis, as the name suggests, is a pear-shaped muscle, originates onto the posterior aspect of the true pelvic cavity on the anterior surface of the sacrum. Between the second third, and fourth sacral foramina, the bone adjacent to it. This muscle exits the pelvic cavity through the greater sciatic foramen. And here we can see the muscle exiting through the greater sciatic foramen, and this muscle attaches to the upper part of the greater trochanter. This muscle is the lateral rotator of the hip joint. On the anterior aspect and the lateral aspect of the true pelvic cavity, we see a fan-shaped muscle. This muscle is Obturator internus. It originates from the obturator membrane on the internal surface of the obturator membrane and the bone adjacent to it. This fan-shaped muscle changes into a small tendon, and the tendon bends at the 90 degrees and exits from the pelvis through the lesser sciatic foramen. This muscle also attaches onto the greater trochanter of the femur, and that is the lateral rotator of the hip. Now I'm going to talk about the fascia over the obturator internus muscle. The fascia over the obturator internus muscle has got two specialization. The lower edge of this fascia gets thickened, and it has got anterior and posterior bony attachment to the body of the posterior part of the body of the pubis and to the ischial spine. And this thickened edge, which I'm pointing right now, is known as tendinous arc or arcus tendinus. This gives attachment to levator ani muscle. So the second specialization of this obturator fascia is along the side of the ischiopubic ramus on its internal aspect where my probe is. At this place, around this area here, the fascia splits up and forms a passage for the pudendal nerve. You can see the pudendal nerve coming here, and the internal pudendal artery, which travel along the ischiopubic ramus in the pudendal canal. The other two muscles of the pelvis form the pelvic floor. The pelvic floor is formed by the levator ani muscle. This is this muscle which we see from the midline all the way on the lateral aspect of the pelvis, hangs down like a bowl, and on the posterior aspect, this is the coccygeus muscle, which completes and closes the outlet of the pelvis. The levator ani takes an attachment from the tendinous arc. It has two components. The anterior part of this is known as pubococcygeus, and the posterior half of this is known as iliococcygeus. The coccygeus is a triangular muscle which gets attachment from the ischial spine, and it attaches to the lower part of the sacrum and the coccyx. The coccygeus muscle lies on the internal surface of the Sacrospinous Ligament. There are some specific fibers of the pubococcygeus which has got very important function on the sphincters inside the floor. These are puborectalis. The puborectalis is the muscle fibers which are attached to the body of the pubis, and they form a sling around the anorectal junction. In case of female, there is sphincter vaginae. These are the muscle which sort of go around the vagina. And in case of the male, these fibers are called as levator prostate, which go around the prostate and support the prostate area. These fibers are difficult to see on a prosection. On this model, I'm going to show the position of the levator ani muscle or the pelvic floor. Here we can see the pelvic floor, which is hanging down from the tendinous arc and the ischial spine, formed by the levator ani muscle and the coccygeus muscle. It is almost like a hammock which closes the pelvic outlet and supports all the viscera inside the pelvic cavity. This is a male hemisection, and we can see here is the rectum on the posterior aspect and the prostate, which is sitting onto the pelvic floor. Above that, there is the urinary bladder. One of the very important function of the pelvic floor or the levator ani muscle is the support the viscera inside the pelvic cavity. This is a hemisection of the female pelvis. We can see this is the position of the pelvic floor, which holds the bladder, the uterus, and the rectum. Apart from having the support of these three organs, it also has got a sphincteric function around the urethra, the vagina, and especially anal canal. A weakness into this floor can lead into the prolapse of these organs or incontinence, urinary incontinence, and the fecal incontinence. To show the position of the levator ani muscle, I'm going to use this model. This triangular canvas represents the position of the left coccygeus muscle. This side, this triangular canvas represents the right coccygeus muscle, which forms the posterior boundary of the pelvic floor or the pelvic diaphragm. This cup represents the right and the left levator ani muscle. If I take this levator ani muscle and fit it into the pelvic cavity, this shows the area of the tendinous arc where the levator ani originates and closes the anterior 2/3 of this opening. If we look the position of the pelvic floor or the diaphragm from below, it hangs like a hammock and or almost like a cup and closes the pelvic outlet. On this hemisection of the male pelvis, let me point out some of the landmarks. This is here on the anterior aspect is the pubic symphysis. On the posterior aspect, here is the sacral promontory, the anterior surface of the sacrum, and the coccyx. We are looking at the posterior wall of the pelvis, and here I'm looking at the lumbosacral plexus. In between these ventral rami of S1, S2, and S3, a muscle here. This is the part of the Piriformis muscle. On the anterior aspect of the pelvis, let me remove the bladder and part of the prostate. The anterolateral aspect, we can see the obturator internus muscle. The fascia over the obturator muscle has been removed, and what I am looking here is the tendinous arc. The anterior attachment of the tendinous arc on the posterior part of the body of the pubis, and the posterior attachment of the arc is the ischial spine, which I am pointing at that. If we look at the inferior aspect of the tendinous arc, we see attachment of these muscle fibers. Anteriorly, we can see the attachment of the levator ani muscle. So this muscle which I'm holding in my hand, this flat, thin muscle, is the part of the levator ani. The anterior aspect of this muscle is the pubococcygeus, and the posterior aspect of this muscle is iliococcygeus. It is difficult to see the specialized fibers like puborectalis or levator prostate fibers in here. This triangular muscle, which is coming from the ischial spine, which I'm sort of holding over my probe, is the coccygeus muscle. Coccygeus and the levator ani muscle, they form the floor of the pelvis, and I can sort of hold this thin muscle, which is your pelvic floor. Let's look at the posterior aspect of these muscles, especially the obturator internus and the piriformis, which are the muscles which leave the pelvis. On the posterior aspect, here is the sacrum. That's the ischial tuberosity. We are into the gluteal region. This is the Sacrotuberous Ligament. The Sacrospinous Ligament is deep down underneath these vessels. This is the greater sciatic foramen, and here we see the Piriformis Muscle, which coming and attaching. This is the greater trochanter. On the upper part of the greater trochanter, we see the attachment of the Piriformis Muscle. The function of this muscle is the lateral rotation of the hip joint. Coming out from the lesser sciatic foramen, which is this opening here, this is the tendon of the obturator internus muscle. It leaves the pelvis by turning at right angle and comes on the posterior aspect of the gluteal region, where it will come and attach onto the greater trochanter. This is also another lateral rotator of the hip. Superior to that is superior gemelli muscle and inferior gemelli muscle. This is a view of the pelvis from the posterior aspect. The sacrum has been removed from here. I want to show you the position of the pelvic floor. Looking here, what we see here is the prostate gland, and these are the right and left seminal vesicle, and this is the ampulla of the Vas, and this is your Vas Deferens on each side. The prostate is sitting on this muscle, which is hanging down like a bowl here. I'm holding the muscle. This muscle is part of your levator ani muscle. The right side and the left side of levator ani comes in the midline, and it attaches to anococcygeal raphe, which is a ligamentous attachment in the middle between the anal opening and the tip of the coccyx. These fibers come on each side and attach. My probe is representing the anococcygeal raphe, and these muscles on the right and left side, the fibers insert onto that. As well as there is a body which is anterior to the anal opening, which is called as perineal body, which is much more important in the female. That becomes the important anchoring position for the many of the perineal muscle. That also gives attachment to some of the fibers of the levator ani muscle. Okay. On this hemisection of the male pelvis, this is the pubic symphysis, sacral promontory, anterior surface of the sacrum, and the coccyx. Posterior to the pubic symphysis, this muscular organ here is the bladder. The anterior surface of the bladder is not covered by the peritoneum. Note here the peritoneum covers the superior surface of the bladder. This is the ureter, and the ureter comes and opens into the bladder at the posterolateral aspect of the tragone. This region around inferior to the bladder is the part of the prostate, and on the posterior aspect of the bladder we can see this pouch. That is your seminal vesicle. The left seminal vesicle we can see here. This tube which I'm holding coming from the deep inguinal ring is the Vas Deferens, and this is the Ampulla of the Vas. The Vas Deferens and the duct for the seminal vesicle, they join together and form an ejaculatory duct which opens in the prostatic part of urethra, which is not distinct here. On the posterior aspect of the pelvis, here we can see a little bit of remnant of the anal canal. This is the position of the rectum. The peritoneum, which covers coming from the anterior abdominal wall, covers the superior surface of the bladder and then reflects onto the rectum. Here it forms a pouch which is known as Uetro-Vesicular pouch. This is the right hemisection of the male pelvis, pubic symphysis, anterior surface of the sacrum, anterior surface of the coccyx. Let's look at some of the male pelvic viscera. Posterior to the pubic symphysis, we are looking this muscular organ. That's the bladder, the reservoir for the urine. When it gets filled, it extends into the abdominal cavity. On the inferior aspect of the bladder, this gland is the prostate gland, and we can see the prostatic part of urethra. My probe is sort of going through the prostatic part of urethra, and this prostatic urethra then becomes the membranous urethra when it passes through the urogenital diaphragm, which is this area around here. And then it becomes the penile urethra going into the penis. On the posterior aspect of the bladder, we are looking at this lobulated pouch. This is the right seminal vesicle. We are looking also here is the Vas Deferens coming from the deep inguinal ring. It enters the pelvic cavity, and this dilated end of the Vas Deferens is known as Ampulla of the Vas. It joins with the duct of the seminal vesicle to form the Ejaculatory Duct, and my probe is into that duct right now. This Ejaculatory Duct brings the sperm and the secretion from the seminal vesicle into the prostatic urethra. On the posterior aspect of the prostate, we are looking here is the lower part of the rectum, and this is here is the anal canal. On this left hemisection of the female pelvis, I'm going to demonstrate the female pelvic viscera. This is the pubic symphysis, anterior abdominal wall, inferior area, the anterior sacral promontory, anterior surface of the sacrum, and the coccyx. We are into the true pelvic cavity. Starting from anterior, this is the bladder, and we can see very short urethra in case of female. Posterior to the bladder, here we look at the uterus. This area of the bladder, which is above the opening of the uterine tube, is the fundus of the uterus. This is the body of the uterus, and this an invaginated area is the cervix of the uterus. Before cervix, there is constricted area here is called as isthmus, or the neck of the uterus. This tube here is the vagina. This is the posterior fornix of vagina, which is sort of a posterior gutter, which is clinically very significant because this area of the vagina is in relation to the pouch of Douglas, or recto-uterine pouch. Through this area, we can feel any contents in the pouch of Douglas, blood, or any collection of the fluid, or any enlargement of the ovaries, any pathology in this area. Let's look at the reflection of the peritoneum. The peritoneum from the anterior abdominal wall reflects onto the superior surface of the bladder and reflects onto the anterior surface of the uterus, and it forms a pouch where my probe is. This pouch is known as Uetro-Vesicular pouch. The peritoneum folds onto the posterior aspect, and then it reflects over the anterior surface of the rectum around this area here. This is the area here is the rectum, and this is the anal canal. When it reflects from the posterior aspect of the uterus to the rectum, here it forms a pouch again. This pouch is known as recto-uterine pouch or pouch of Douglas, which lies in relation to the posterior fornix of vagina. This area of the peritoneum, which I'm pointing, is the broad ligament. The broad ligament is two-fold of peritoneum, which hangs on the side of the uterus over the uterine tube. Let me demonstrate the position of the broad ligament on a model. On this model, here we look at the fundus of the uterus, the body of the uterus, the isthmus of the uterus, and this is the cervix of the uterus. There is the external os, which is invaginating into the vagina. This is the vagina here. The broad ligament is shown here with the blue color, and that wraps the uterus over the fundus, and it wraps the fallopian tubes. The broad ligament is the two layer of the peritoneum through which the blood vessels from the lateral pelvic wall, the nerves, the lymphatics enter to these organs. They are a distinct part of the broad ligament. The area of the broad ligament, which is near the fallopian tube, around this area here, is known as mesosalpinx. The posterior layer of the broad ligament, which holds the ovaries, and this shelf of the broad ligament is known as meso-ovarian. The area of the broad ligament, which is on the side of the uterus, is known as mesometrium. And basically, it conveys the blood vessels, nerves, and lymphatics to these different pelvic viscera. The normal position of the uterus is described as anti-flexed and antiverted. That means flex forward and it is curved forward. The antiversion is an angle between the long axis of vagina and the long axis of the cervix. So this angle around here is angle of antiversion. Antiflexion is the angle when the body of the uterus forms an angle with the long axis of the cervix. So around this area here, which is almost bent forward. Sometime in some of the women, we see a retroverted and retroflex uterus when the uterus is bent backwards over the rectum. The uterus is positioned and supported by 4 structures inside the pelvic cavity. There are 3 ligaments and the pelvic floor or the pelvic diaphragm, which supports uterus in its position. The 3 ligaments are nothing but the condensation of pelvic fascia. These ligaments anchor the uterus anteriorly to the pubic bone, posteriorly to the sacrum, and laterally the side of the pelvic cavity. The pelvic floor supports it from inferiorly. It's very difficult to see these ligaments in wet prosection. What I am going to do is going to demonstrate on this model the position of these 3 important ligaments, which are called as cardinal ligament, pubocervical ligament, and uterosacral ligament. By the probe, I'm showing the position of the lateral or cardinal ligament. This condensation of fascia anchors the uterus with the lateral pelvic wall. The pubocervical ligament anchors the base of the uterus to the body of the pubis. The Uetro-Sacral ligament, which is not present here, but this probe represents the position of the Uetro-Sacral ligament, and it attaches the uterus to the sacrum. A weakness of these three ligaments and the pelvic floor can lead to the prolapse of the uterus. Prolapse of the uterus can be different degrees. It can prolapse inside the vagina, or it can come out in the severe prolapse. It can come out from the external os or the opening of the vagina outside into the perineum. Here we are looking on the left uterine tube. This dilated end of the tube is known as ampulla of the uterine tube, like a trumpet. At the edge of this ampulla, we see these finger-like projection, and these are called as fimbria. The fimbria surround an opening which is called as ostium. The egg enters the uterine tube through the ostium by the movements of the fimbrias. The narrow portion here is known as isthmus. At the junction of the lateral 1/3 and the 2/3, this is where the fertilization of the ovum takes place. The area of this peritoneum which we are looking here is the part of the mesosalpinx. This oval shaped organ is the ovaries. This is the left ovary. This is the round ligament of the ovary, and this fold of the peritoneum which is holding the ovaries is known as meso-ovarian. What I'm holding here is the ovarian vessels, nerves, and the lymphatics which enter through this area of the broad ligament, which is called as suspensory ligament, and these vessels then reach through the meso-ovarian to the ovaries. This is the third part of the video and the last part. Now I'm going to demonstrate the blood supply of the pelvis. The main artery which supplies the area of the pelvis and also gives the branch for the perineum is the internal iliac artery. The internal iliac artery, it is a branch from the common iliac artery, and it gives somatic and visceral branches in the pelvis. And also it gives a big branch which goes in the area of the perineum. The branching pattern is very variable, so we are going to look at the main branches on a wet prosection which will be supplying the different areas of the pelvis. The blood supply of the pelvic region. We start with looking at the abdominal aorta. The abdominal aorta at the level of L4 divides into right and left common iliac artery. Here we are looking at the left common iliac artery, which at the sacroiliac joint divides into internal iliac artery and external iliac artery. External iliac artery, if I trace this down, passes through the inguinal ligament where it becomes the femoral artery, and that will supply, that is the single artery which supplies the lower limb. Let's look at the internal iliac artery. It crosses the pelvic brim and enters inside the true pelvic cavity. The branching of the internal iliac artery is very variable. It divides into anterior division and a posterior division. From the posterior division, we see a very important and big branch, which I am sort of pointing here, is the superior gluteal artery. Superior gluteal artery leaves the pelvis between the lumbosacral trunk, which is formed by the ventral rami of the partial part of the L4 and full ventral rami of L5, and between the S1 ventral rami. This supplies the gluteal minimus and the hip joint. The first branch, which we are looking here, which is high up, it should be coming around somewhere around this area of the posterior division. This is the iliolumbar artery, which supplies the iliacus muscle, psoas muscle, and the region of the sacrum and the lumbar region. Here we see the lateral sacral branches. Again, it's quite variable. Sometimes there is one branch giving different branches. Here we are looking at the two branches, and that supplies the area of the sacrum, the ventral rami, and the dura inside here. Anterior division, the branching of the anterior division is quite variable. You have to follow the artery to its termination. It forms a cloth line arrangements. The continuation of the anterior division forms the obliterated umbilical artery. The obliterated umbilical artery gives the superior vesicular branches to supply the superior aspect of the bladder. This artery, if you continues on to the anterior abdominal wall, where it forms the medial umbilical fold underneath the peritoneum. The first branch is the inferior gluteal artery. Inferior gluteal artery leaves the pelvis through the greater sciatic foramen, just like superior gluteal artery, and supplies the gluteal maximus muscle and the structures in the gluteal region. The second branch of the anterior division is the internal pudendal artery. Internal pudendal artery is the artery of the perineum, which supplies the external genitalia and the muscles of the perineum. This artery exits through the greater sciatic foramen and re-enters the perineum through the lesser sciatic foramen. The next artery, which we are looking here, is going towards, if we follow this, this is running with a nerve here, which this nerve is the obturator nerve. So this is the obturator artery. The obturator artery and the obturator nerve with the obturator vein, which is not present here, leaves the pelvis through the obturator opening. And my probe is inside the obturator foramen, and from there it enters the medial compartment of the thigh. This is a female prosection, and one of the very important branch which we see here, which is going to supply the uterus, part of vagina, and also anastomose with ovarian artery. This is uterine artery. The uterine artery forms a very important clinical relationship at the base of the broad ligament of base of the uterus with the ureter. Here is the ureter, which is coming from the posterior abdominal wall. It crosses the division of the common iliac artery, crosses the pelvic brim, and changes its direction to anteriorly, where it is crossed by the uterine artery. This relationship sometimes referred as water under the bridge. During the operation of which is called as hysterectomy, which is when the uterus is removed, clamping this artery requires removing the ureter adjacent in this area or lying inferior to this artery. There are few inferior vesicle branches which are supplied the lower part of the bladder, and in case of male, these also supply the prostate and the Vas Deferens and Seminal Vesicle. That completes the blood supply of the pelvis. So we get all the blood supply from internal iliac arteries. There are visceral branches and somatic branches. Visceral branches are going to different organs, and somatic branches supply the body wall.